In myeloma, as our patients go through treatment, we want to maximize the duration of first-line therapy. And in fact, if you look at induction, that is optimal, followed by stem cell transplant, and then maintenance, one can start envisioning about 5 years on the average of disease control. Then you take one of these optimal regimens for a first relapse, which could be, for instance, KRD or DARA-RD. We're adding another 2 to 3 years. So we're talking about 7 to 8 years for initial therapy. Now, for that patient, they still have a good number of options, and I would venture out to say that we have to consider both the comorbidities, as we mentioned previously, the tolerance to the previous regimen, and also the goals of therapy at that point. There are some patients for whom intensive aggressive therapy is still warranted. And in fact, that may even take us all the way back to consider another stem cell transplant. So if I had a patient that goes through a transplant and after several years gets one of those regimens and gets a few other years, and then the patient is facing again the possibility of a relapse. Let's say I have a patient who was treated with KRD, and now it's experiencing a relapse 2 or 3 years later, and the patient is fit. Hey, why not? I may consider daratumumab, pomalidomide, and dexamethasone as a prelude to doing a second stem cell transplant. So all of those factors come into play as we decide on the next lines of therapy. Now, there may be a patient who's quite frail, where we may want to minimize the toxicity. We may want to allow them to spend more time, for instance, with their families. But I would say the average myeloma patient who's able to reach the second and third relapse line of therapy should know that there's a plethora of options still available to them.
Choosing treatment is an important part of the physician's role in the management of myeloma. And it seems to me that there are a number of thought processes that govern the treatment, and kind of some physicians see frontline treatment with one triplet, first relapse with a different triplet with a different mechanism of action, then third line with yet another triplet, and they should always be different with different mechanisms. But as we've discussed, not all relapses are the same. So that simple idea of it's just triplets doesn't necessarily work out for every patient. And so if you've had a good response to a transplant, you can use a transplant. Again, if you've been treated with carfilzomib, you tolerated it well, you've been in remission for 3 years, it's just as likely that it will work at that relapse as it did at presentation. So I think you always have to consider the type of relapse, type of disease, restage, aim for maximum response, then aim to control the disease during remission by longer term exposure. And I think that's the real clinical conundrum, not alternating triplets every 2 years.